Assalamu alaikum and good morning. My case is going similar to the few cases which were presented. It's not a major departure from the other cases. So what we have is a 64, and this is the true age of the patients, not 65, which met the guidelines. A 64-year-old man with type 2 diabetes. He's obese, hypertension, hyperlipidemia, and is known to have history of paroxysmal atrial fibrillation for the last 5 years and has been placed on anticoagulation with Coumadin. He was evaluated at outlying institution for a complaint of epigastric pain. He had endoscopy, which reported to have an acute gastritis. We don't have an H. pylori status on him. At the same time, he underwent a treadmill, which was positive at 5 minutes of exercise. His examination was unremarkable, except for a sclerotic murmur. His medication on arrival from the other institution were warfarin. He take Alaa, Codiabon, simvastatin low dose, and he take anti-diabetic medication. And his labs, as mentioned, sugar is slightly elevated, renal function is normal, electrolyte unremarkable, his troponin is negative, and his INR was 2.2, normal hemoglobin and platelet count. An EKG documented that he was in sinus rhythm, and in the hospital, my colleague decided to the following: his Coumadin has been held, and he was loaded or given initially 325 milligram of aspirin. Then the consultant decreased the dose to 81 milligram, and he was started on Plavix, 75 milligram. He was also started on omeprazole because of his reported acute gastritis, and his statin was changed to a higher dose, atorvastatin, and the plan was to cath him when his INR less than 1.5. And indeed, this is what happened, and as you could see, he had really a critical proximal LAD stenosis, another tight proximal right, as well as a distal right stenosis. So to summarize, he's a 64-year-old gentleman with history of paroxysmal AFib and severe symptomatic 2-vessel disease involving the proximal LAD. He was found to have an acute gastritis and non-H. pylori status. So his risk evaluation, he has CHA2 VASC 3 and has blood score, providing we're counting as a 64 as 1. So what's the decision process in this? Should we proceed with PCI with bare metal stent, give him triple therapy for 1 month and dual therapy after that with anticoagulation? Or shall we proceed with PCI with drug-eluting stent, triple therapy for 3 months, then dual therapy? Or the third option, 6 months triple therapy and then dual therapy, or triple therapy for 12 months, or forget about all stenting and send him to Cabbage, to Dr. Tamim, and give, since he had a proximal LAD, and start him on anticoagulation. The possibility of treatment of a regimen, anticoagulant regimen in AFib is really bewildering. I mean, if you look at the mathematical opportunity of the cumulative number, we probably have more than 1 million possibility of treating regimen. So aspirin could be used at a low or a high dose. The duration, 1 month, has been tried 3, 6, and 12. And the thiopyridine, we have 3 of them. And again, it has been in different trial, at least 4 regimen has been tried. Anticoagulant now is becoming really increasing, and every day we have a new number. And what regimen should we use? Is it a high intensity, lower intensity? And we're really not sure what. I like this slide. It summarizes our option. We're going anywhere with the length, anywhere from a short to a long trial, and that reflects the status of our thinking and management of this patient. And then this patient have an acute gastritis. What about the issue with type 2 C119 inhibition with omeprazole and esomeprazole? We still have a black box warning from the FDA, and every time you prescribe this, you get a call from the pharmacist. This is the best medication, or shall you switch him to pantoprazole? And then if this is the case, what's the dose of Plavix which we should use? Should we use double Plavix or the 75 milligram? And, or should we use a different agent like Brilinta rather than clopidogrel? And how about the issue, should we use the PPI routinely to prevent the bleeding? And all these issues are still not settled, and we're getting controversial things from the guidelines. So in our patient, what we decided to do the following. We proceed with the PCI of the two of the lesion with a the newest generation Zetrolumus stent. We have discharged him on triple therapy for 6 months. And after that, we decided to keep him on aspirin and at 81 milligram, as well warfarin. We decided to continue the omeprazole, minding the guidelines, which probably has been challenged recently. I'm hoping that you could really enlighten us with a guideline or an agreement about what's the best clinical scenario to deal with those patients. Thank you.